Hi, I'm Dr. Mehboob, MD Ophthalmology from AIIMS, New Delhi. And today is a very important session, that is Neet PG Recall 2021 Ophthalmology. Previously in the Neet PG, 10 MCQs from the ophthalmology have been asked among 200 MCQs. So you can imagine the importance of ophthalmology in the Neet PG. Among 200 questions this has been asked, means this is carrying the 5% weightage. Okay, and questions are not so hard, they are very easy, and you can, if you have the basic concepts and the common knowledge of different MCQs, you will be able to solve among 8 out of the 10 very easily. So before we start, just subscribe and share to your friend and click the bell icon, because you will get another important same MCQs, revisions, questions, and most important that I have started a series of images in ophthalmology part 1. I have uploaded only, the part 1 has been uploaded only on the YouTube. So you go there and watch that, that's very important, and the subsequent part of that image is very important, is going to come before the exam. And why I'm saying that, because images in this scenario, the questions have been asked so much only especially in the ophthalmology, from the images only. And if you have the good image knowledge, your basic concept is also clear, then you will be able to score the maximum in the ophthalmology. So without delaying, just starting with this Neet PG recall, very important to revise before exam. The question is saying, identify the site of the lesion if the patient can't see the right visual field images of both the eye. Right visual field means right visual field images. This eye, right eye ka right visual field, this one, that is temporal, and left eye ka left visual field, this one. The photo was not given in the exam. The photo was not given in the exam. You have to draw in your mind. So let me draw here for you. The patient this is right, this is left. So they are saying that this is right eye, this is left eye. He is saying that the patient can't see the right visual field, means this one, of both the eye, the right side, the right. So this is the visual field of the patient. Now it's very easy to understand, right? 3 golden rules. I will tell you the many mechanisms, but you will get confused. 3 golden rules to solve this type of question. 1. Before optic chiasma, second, at optic chiasma, and third, after optic chiasma. So you know there is an optic nerve, then optic nerve crossing over the nasal fibers is crossing over the optic chiasma, and then there is a optic tract, and there is a optic radiations going to the occipital lobe or occipital cortex, striacortex, right, whatever. Okay, then most of them are very much confused कि क्या होगा, कहाँ lesion होगा, where their lesion is, and what is the resultant field. For your label, very simple to remember, optic chiasma के before, optic chiasma after, and at optic chiasma. Before optic chiasma, complete blindness of the same eye, complete blindness of the same or ipsilateral eye. So remember, complete blindness, same eye, complete blindness of same eye. Ipsilateral, more common technical term, but for you I am telling you. At optic chiasma, it is bitemporal hemianopia, bitemporal hemianopia. And after optic chiasma, always remember contralateral homonymous hemianopia. Homonymous Hemianopia. Now what is homonymous hemianopia? Homonymous means of the same side, right? Like in this question, same side, na? Right side of both eye means same side of the both eye. So this is homonymous. Okay, so obviously going by this rule, the homonymous hemianopia will always take place after the optic chiasma. So going by this rule, that the lesion will be always after the optic chiasma only, because we know that after optic chiasma there is a homonymous hemianopia. Now since it is a right sided and I have written its contralateral, since it is right sided and I have written its contralateral, obviously the lesion will be in the left side. Left side lesion will be in the left side and after the optic chiasma. So let's search in the option left optic tract. Our answer is this. Left optic tract is after the optic chiasma and obviously this is on the left side. So the answer is this. You got the answer. Now coming to the other options. Optic chiasma, but on the optic chiasma the lesion will be the defect will be bitemporal hemianopia. It is not like that. Left occipital lobe. Left occipital lobe. You know, the thing is that you can get confused by the left occipital lobe because it is quite posterior. It is also after the optic chiasma, but it is quite posterior, and there is something which is called macula sparing thing, right? The macula sparing thing will be there. So obviously all the fibers are not actually injured in this left occipital lobe because it is very posterior. So that's why the answer here is optic tract only. Right optic nerve, it is before the optic chiasma and also it is right side. So it will give the complete blindness, not this half blindness. So you got my point now. General, these are for the general rules, not going into the complexities. If you go into the complexity, you will get confused. I have another separate video where I have discussed a very important detailed analysis in just 5 to 7 minutes of this field. Just go to that video if you want to, and you will get to know everything that you want to know about this field, but at your level only, but up your level, not the post graduation or the super specialization level, not that, because that goes beyond the scope of your level, right? So answer, you got it. For the simplification, I have written these 3 things. Just see, this is the optic nerve, this is optic chiasma, and this is beyond. This is optic tract, this is optic radiation. See the visual cortex. The visual cortex is very much posterior. Occipital lobe here, na? So it is never going to give you like this one. Optic tract will be there. So obviously the optic tract will give you the whole contralateral homonymous hemianopia only. So there are the 2 things that you need to know. I am not going to discuss much more here. Just 2 things that you need to discuss. One is the pi. Here, look at here. Pi in sky. That is, pi in sky will look like this only. Look like this only. There is a defect here only. Okay, only the half. The lesion will be in temporal lobe, and pi on floor, the lesion will be like this one, and the lesion will be in the parietal lobe. So this is very important. You just remember this one. Now for the concept, which temporal lobe is involved here? Contralateral, left sided, na? Left sided is involved. So obviously right temporal lobe lesion is there. And pine floor, which side? Contralateral side. Obviously it's the left side, so obviously right parietal lobe is injured. So this is very important to understand these 2 things. And for detailed analysis, go to the separate video, subscribe, and go to the separate video in the videos in my channel, and you will get to know many things in just 5 to 7 minutes. Thank you. And once your short questions from this question, this is very important. Coming to this second important question. A person has a chisel injury while cutting a stone. Most of us, and so see which investigation is detrimental to diagnosis, means which investigation you should avoid: X-ray, MRI, CT scan, ultrasound B scan. Chisel injury means iron injury. Very simple. Chisel means iron injury, and the iron is a metal. Since iron is a metal, obviously all those investigation which is avoiding in the metallic formality, because in MRI what you do, you remove all those things, all those metallic ornaments from the body, and then you do a MRI. Why? Because the alignment of H plus iron is not possible unless you remove all those metallic things. And since it is metallic body, iron is a metallic body, you are not going to do MRI because it will not be more significant in that situation. So the answer is very simple, MRI. What is the first investigation if they ask you you will be doing in this injury? Suppose a person, most in Indian scenario, most of the iron chisel or iron rod cutters, they do not wear the spectacles. So it's very common, this injury. Okay, this injury is very common, and just like when the iron is entering into the cornea or the conjunctiva, they can go up to the retina and can also go beyond that. They can embed into the different parts of the eye, like in the muscles, ocular coats, retina, in the vitreous, in the lens, iris, in the angle of the anywhere. Just you have to see and follow the route of the entry. How do you find the route of the entry? If it is not visible on the slit lamp clearly, just do the fluorescent staining. This is one of the things. Suppose there are the different types of the foreign body which can enter into the body. So which is very much detrimental? The vegetative matter or the contaminated foreign body are very much detrimental because they induce the infection very fastly. They lead to the endophthalmitis condition, and in that scenario, that is, you have to work actively. Okay. The second thing that they can ask you about the inert foreign body. Inert foreign body are the glass. Inert foreign body are gold and silver. These three are very much inert, right? First investigation that you will do is X-ray. CT scan is the investigation of choice. In case you want to know the exact location of the foreign body, you have to go for the CT scan. Ultrasonography of B scan can only give the hyperreflectivity of that area, and it will not with certainty tell you about the presence of the foreign body, right? The second thing is that in the iron foreign body, the electroretinogram will be flat, that is B wave is flat, because there is the RP atrophy. Iron will lead to siderosis and copper will lead to chalcosis. But if somebody asks you that this copper, whether the pure copper will lead to chalcosis or other things, pure copper will not lead to the chalcosis. It is the alloy of the copper will lead to the chalcosis. Pure copper is very much dangerous. Pure copper induces fast endophthalmitis, infection, inflammation. But the chalcosis is induced by the alloy, brass and bronze that is important. Okay, so it's very important to act actively during this type of injury. And you have to ask them to wear the glasses while doing their work. This is very important safety measure. Coming to the third important question, most common complication of the following conditions. Can you see this condition? Let me enlarge for you. Can you see this? See, there is an upper lid coloboma. Can you see here? This is upper eyelid coloboma. And whenever the patient is trying to close his eyes, this portion will always be open. So what is the most common complication? Exposure keratopathy, cataract, amblyopia, or restricted movement? Obviously, the answer will be exposure keratopathy, because this much portion of the cornea will remain be open, and this will lead to the, obviously, just like in the Bell's palsy, where you just do the strapping because of the non-closure of the eye, right? Similarly, you have to suture it, make it by doing the lidoplasty, that is blepharoplasty, like the thing you have to do. So this is very important, nothing more serious. You just need to apply your common brain to make this question. Which glycosaminoglycans maintains the corneal transparency? See, there are so many things which is important for the maintaining of the corneal transparency. What are those things? Somebody says that in the stroma, the lens fibers are very much parallel. So the light which is coming is actually the interactions what is happening there. There is a negative interference will take place and it will be acting like there is a nothing in between. One, this is Morris theory. Second thing is that the fibers are so small that the light small compared to the light, that's why the fibers are not interfering to the transmission of light. Third thing is the presence of endothelial cell pump. Third thing is the presence of endothelial cells pump, that is sodium potassium ATPase pump, which is important for maintaining the relative dehydration. That's the term important, relative dehydration of the cornea, which is maintaining the transparency. And there is yet another thing that is called stromal pressure. Now coming to the important thing called stromal pressure. There is a IP, that is imbibition pressure, IOP intraocular pressure minus stromal pressure. So you have to maintain this imbibition pressure to keep the cornea transparent. Why and how this cornea becomes transparent? Because of this stromal pressure. This stromal pressure is contributed by GAG, means glycosaminoglycan, right? Glycosaminoglycans. Now these are all the glycosaminoglycans, and you need to know that in the stroma, the glycosaminoglycan, like the keratin sulfate, ratio of keratin sulfate is to chondroitin sulfate is 3:1, means the abundance of this keratin sulfate is more, which is contributing more to this pressure, which is contributing more to the corneal transparency. So the answer here is C, keratin sulfate. One more important question they can ask you, which is the most common collagen which is present in the stroma, epithelium, Bowman's membrane? The answer will be type 1. However, 5 is also present, 4 is also present, 6 is also present, but most common is type 1. The third thing is that the number of endothelial cells present at the time of birth is 6,000 cubic per millimeter cube, which is but the normal endothelial cell count is only 2400 to 3000. 2400 to 3000. This is all about this question. I think you have got the right explanation. Coming to this one, just moving fastly with the rest of the questions. A 15-year-old child came with the recent non-acceptance of regular glass for myopic astigmatism. What will be the viable option? The patient is having 15 साल का बच्चा है, non-acceptance of the regular glass. He is having a myopia. 15 year, you have to see non-acceptance. So the three things is there. 15 साल, non-acceptance of the myopia, right? Means he is not accepting the normal spherical glasses. Then what is the most important variable thing that you can do? A spherical equivalent spectacle, LASIK, femtolasic, or implantable collimal lens. See, what is you have to see, because at the age of 15 year, the eye is still growing, the eye is still changing. So you cannot give anything which is permanent. As you know that LASIK, femtolasic, these are all the things which is done after 18 years of age. Simple. Implantable collimal lens. However, these two things are permanent, but this is reversible. I know this is reversible, ICL is reversible, but it is invasive procedure, and you cannot do the invasive procedure again and again. So The answer will be, we are left with the spherical equivalent spectacles. Most of the patient of this type which is not accepting the myopic astigmatism, they will accept this spherical equivalent. And you have to understand just the basic rule that you cannot go into any laser surgery or any refractive surgeries, any refractive things before 18 years. This is the basic or simple concept behind this question. A patient is suffering from the diabetes and hypertension. The given picture of his retina is due to diabetic है, hypertension भी है. What is the answer? Soft exudate due to hypertension, hard exudates due to CRAO, hard exudate due to diabetes, and flame-shaped hemorrhage due to hypertension. Can you see this? Can you find any hemorrhages here? Very few hemorrhages. You know, hypertension में flame-shaped hemorrhage is much more common, and diabetes में dot hemorrhage is much more common. However, these hard exudates are purely mainly because of the diabetes, because this patient is giving the history of diabetic itself. CRAO में अगर hard exudates होते भी, they can take place, but CRAO is one thing that the retina will not look like this grays, this color. It will be look like grays, and you will find the cherry red spot, right? So obviously this is on the soft exudate. This is not at all the soft exudate. It's a bright yellow color with a distinct border, and that's why soft exudates is ruled out. CRAO, color of the retina is normal, no cherry red spot. However, so obviously B is ruled out. Hard exudates, obviously this is hard exudates, and flame-shaped hemorrhage is not seen. So that's why D is ruled out and C is our answer. Got it? Now coming to this, a newborn child with a big blue eyes and watering. Big blue eyes and watering. What is the answer? Congenital glaucoma, mucopolysaccharide, cataract, ophthalmia neonatum. Since it is a newborn and this is congenital corneal opacity, right? So you know about the 7 things, very simple. You know about the STUMPED, stumped. S for sclerocornea, T for tear in basement membrane, basement membrane, U for ulceration, M for mucopolysaccharide, P for Peter anomaly, E for endothelial dysfunction, that is CHED example, congenital hypertrophic endothelial dystrophy, and D for dermoid. So these are the stumped, right? Now coming to this, since this child is having the congenital corneal opacity, obviously you know about that, then we are left with only 2 options here, because stumped has told me that only 2 things which is matching from this here. That is congenital glaucoma and mucopolysaccharide. Cataract is not at all the cause of the blue cornea. Ophthalmia neonatum, obviously not at all the cause of the blue cornea or the corneal opacity. But if there is a corneal, there is a neonatum, the conjunctiva will also be involved in this condition, the lid also be involved. So obviously these 2, C and D is ruled out. We are left with the congenital glaucoma and the mucopolysaccharide, right? Now you have to answer that why it is congenital glaucoma and why it is mucopolysaccharide. Very simple to understand that the question has the hint of big blue eyes, and in the congenital glaucoma, what we also call it is as bophthalmos because of the large size. Or obviously if you measure the IOP is also increased, and the most common feature, that is the watering and the photophobia in this child, is very much common. So the answer for this question is congenital glaucoma. Coming to this 8th number question, can you see this? A patient with a history of the contact lens used for 2 years now presents with a sign as in the picture. Can you see this picture? Giant papilla, can you see this? This is the goal papilla. This was the exact picture which is given in the exam, and very much this is a giant this cannot be follicle. This is not a follicle. Follicle does not have a blood vessels like blood vessels like around this at the apexes. The papilla will have the blood vessels pointing at the apex, right? That's why it's a papilla, no? So the answer, very important to understand, the answer here is giant papillary conjunctivitis from the question only, because the most common cause of this giant papillary conjunctivitis is the contact lens user for the long time, or if something means you have done suturing and the constant irritation of suture to the tarsal or tarsal conjunctiva, they will give like this look, okay, or ocular prosthesis, okay. So these three things like contact lens, sutures, or the prosthesis, ocular prosthesis, they will give rise to the giant papillary conjunctivitis. Contact lens के जगह पे they would have given you the ocular prosthesis also, the sutures also. Follicle, obviously this is not a follicle at all. Vernal, this is L, not K. This is L. Vernal keratoconjunctivitis, VKC, obviously there is no Herbert P, nothing like that features or history of itchings, or this papilla is there obviously, but not so giant, and obviously contact lens use is ruling out this feature, okay. And also obviously in the limbal area there is also the papilla seen in the VKC. Thus the history should also contain the history of the season. That is very important. Intense itching will take place in the vernal keratin. And trachoma, obviously there is a follicle in the trachoma, there is a tracheasis in the trachoma. In the tarsal conjunctiva, you will have to see that trachoma has the Arlt's line, that is subtarsal scarring, right? So this is obviously, this is pointing towards the giant papillary conjunctivitis. Coming to this one, 9th number question is saying that history of dryness, corneal softening, and night blindness and gritty sensation. Night blindness, corneal softening, gritty sensation will lead to what? The above symptoms is because of which vitamin deficiency? Obviously, iron is not a vitamin, protein is not a vitamin. You can rule out it like that only. But see, the question should have asked that which of the following is deficient. Basically, this dryness, that is xerosis, softening, xerophthalmia, night blindness, obviously nyctalopia, and gritty sensation, xerostomia, right? So these are all the features of the vitamin A deficiency. You know, this is actually xerophthalmia, and obviously the answer will be what? Retinoic acid. Accordingly, you have to treat the patient. So since we are very much slow, that's why we are going to the question number 10. That is the last question of AIIMS, which have been asked. A child with unilateral papillary reflex for which the surgery was done. Biopsy showed the specimen having the flexor Winter-Steiner rosette. Which of the following diagnosis? Flexor Winter-Steiner rosette. FW rosette. What is the diagnosis of this? The surgery is required for that. What do you think that should be answer? However, this is unilateral pupillary reflex. It's not a white pupillary reflex that has been given, but biopsy of the surgical showed the flexor Winter-Steiner. You can see that in the retinoblastoma, medulloblastoma, rhabdomyosarcoma, and astrocytoma, where you will see the flexor Winter-Steiner rosette. Obviously, retinoblastoma will show. The retinoblastoma is the most common thing. Don't go by this just unilateral. They can have the unilateral pupillary reflex. It's not compulsory that they will have always the bilateral. So the answer, the most probable answer for this question, obviously it is also present in the medulloblastoma, but the most probable answer for this question is retinoblastoma. That's why this retinoblastoma makes it very important. Homerite rosette or flexor Winter-Steiner rosette or pseudo rosette, all three are present in the retinoblastoma, and that's why you have to mark it, because you have to mark the commonest thing, not just go until and unless the question is pointing towards the specific thing. So the answer for this question is here. Thank you for the great listening, and please subscribe and share for more video. I hope you like this, and we are also preparing for the most 100 MCQs marathon before the exam. So stay tuned, click the bell icon. Thank you very much.